Most neonatal jaundice is harmless and physiological in nature due to the fetal circulation having a greater number of red blood cells with a shorter lifespan. At birth, these are no longer needed, and bilirubin is formed as the red blood cells are broken down. Most of the bilirubin is metabolized by the liver and is excreted in the urine and stool. Bilirubin exists in two forms, unconjugated and conjugated. Unconjugated bilirubin is insoluble in water. This means it can only travel in the bloodstream if bound to albumin, and it cannot be directly excreted from the body. In contrast, conjugated bilirubin is water-soluble. This allows it to travel through the bloodstream without requiring transport proteins like albumin, which means that it can also be excreted out of the body. This diagram illustrates the process. When looking for signs of pathological jaundice, always consider the following factors: infection, polycythemia, concealed hemorrhages, such as cephalhematoma or excessive bruising, dehydration, increased enterohepatic circulation, impaired liver function or liver enzyme defects, and metabolic disorders. However, we should always consider other factors in the newborn as the cause of jaundice. The images on this slide illustrate the symptoms of a concealed hemorrhage, or cephalohematoma. Jaundice may also occur as a result of pathological factors such as blood group incompatibility or known maternal antibodies, blood cell disorders such as spherocytosis, infection, trauma and bruising, conditions affecting the biliary system, such as biliary atresia, and metabolic disorders. The etiology of biliary atresia is not well understood, but genetic factors, viral infections, toxins, chronic inflammation, and autoimmune injury to bile ducts seem to play a role in the pathogenesis. Biliary atresia cases have atretic extrahepatic bile ducts, which obstruct bile flow out of the liver. Relieving this obstruction is the focus of the Kasai portoenterostomy procedure, which connects the liver and intestines directly, in an attempt to establish bile flow. All untreated cases develop cirrhosis, progressing to end-stage liver disease, and the need for a liver transplant within the first 2 years of life. Even with treatment, disease progression often continues and explains why biliary atresia is the most common indication for liver transplant in pediatrics, despite having an incidence of only 1 in 5 to 20,000. So, how do we differentiate between physiological jaundice and pathological jaundice? Pathological jaundice is jaundice that appears when the baby is less than 24 hours old. It is indicated by a rise of serum bilirubin by 8.5 micromoles per hour, and you will have a very sick baby. In the case of early jaundice, presenting in the first 24 hours, investigate, as matter of urgency. Check serum bilirubin levels, and plot accurately the full blood count, CRP and cultures, blood group and direct antiglobulin test, and the maternal blood group and rhesus factor. In regards to neonatal infection and jaundice, clinical statistics reveal that the incidence of neonatal pathological jaundice is on the rise, and bacterial infection is the major factor causing neonatal pathological jaundice. Bacteria such as E. coli, Listeria and Group B Streptococcus are common bacteria that can cause neonatal infections. Congenital viral infections, for example, syphilis, toxoplasmosis, CMV HIV, herpes virus, and rubella, can cause jaundice. Toxoplasmosis is caused by a parasite called Toxoplasma gondii. Infection can occur from eating undercooked meat or coming into contact with cat feces. The parasite can pass on to the baby during pregnancy. Most people infected can have flu-like symptoms, or none at all. Serious disease most often affects infants and people with weakened immune systems. Toxoplasmosis during pregnancy may cause miscarriage and birth defects. In the case of the cytomegalovirus, or the herpes virus family, for most healthy adults and children, CMV does not cause any noticeable symptoms or long-term effects. In some cases, a healthy adult or child may develop cold or flu-like symptoms. However, if a woman catches CMV for the first time while pregnant, particularly during early pregnancy, CMV can have long-term effects on the unborn baby, including deafness and blindness. CMV is found in bodily fluids such as saliva, urine, semen, and others. The virus is easily spread in households and in daycare centers. Jaundice occurring within the first 24 hours is most likely to be hemolytic in origin. This is potentially dangerous due to the neurotoxicity of unconjugated bilirubin. SBR levels may rise rapidly. The two most commonly recognized forms of hemolytic jaundice in newborns are due to rhesus and ABO incompatibility. Rhesus incompatibility occurs when a mother who is type rhesus negative is pregnant with a baby who is rhesus positive. If there is any mixing of maternal and fetal blood during pregnancy or the birthing process, the mother's anti-rhesus antibodies will vigorously attack the baby's rhesus-positive red blood cells by adhering to and subsequently destroying the baby's cells. The rhesus factor is an inherited protein. Rhesus hemolytic disease is the most severe form of this condition. It begins in utero, with babies presenting at birth as anemic, hydropic, and jaundiced with hepatosplenomegaly. During the first and subsequent pregnancies, the antibodies are able to pass through the placenta into the fetus, causing destruction of rhesus-positive fetal red blood cells, and leading to the development of rhesus, or hemolytic disease of the newborn. Generally, rhesus disease becomes worse with each additional rhesus-incompatible pregnancy. This diagram illustrates this process in more detail. Now, please watch the following short video.
Hi, this is Tom from ZeroToFinals.com. In this video I'm going to go through rhesus incompatibility because it's a bit of a tricky subject to get your head around, but once you get your head around it, it's really quite simple. So to start with, it's important to realise that the mum and the baby have quite different blood types. The baby has its own unique blood type because it inherits half of its genetic makeup from its father. The mum and the baby's blood don't actually mix, but they come in very close contact with each other across the placental membrane. When somebody talks about their blood group, they might say they're A positive or B positive or O negative. The first letter is their blood type, and the second character, the positive or negative, is their rhesus status. And if somebody's rhesus positive, it means that their red blood cells have the rhesus antigen on them. If somebody's rhesus negative, let's say O negative, it means that their red blood cells don't have that rhesus antigen on them. So why is this important in pregnancy? It's important because of one scenario, and that's where the mum is rhesus negative and the baby is rhesus positive. To understand why this is important, we need to look at what happens when you have the rhesus antigen. If you have the rhesus antigen on your red blood cells, your body learns to recognize that antigen as being part of your body, so it doesn't attack it. But when you don't have the rhesus antigen on your red blood cells, and you come in contact with that antigen, your body thinks that that is a pathogen and it needs to attack it. Let's say you were transfused with blood that contained the rhesus antigen, and your body didn't have the rhesus antigen, then your B cells of your immune system would recognize that this is something that doesn't belong to your body, and it would launch an immune response and create something called antibodies against that rhesus antigen. And we call these anti-D antibodies. So why is this important in pregnancy? Well, if the mum is rhesus positive, we've got nothing to worry about, because that baby can be rhesus negative or rhesus positive, and she's never going to try and attack that baby's blood cells. But if that mum is rhesus negative, meaning that she doesn't have the antigen on her red blood cells, and the baby is rhesus positive, meaning that he or she does have the rhesus antigen on their red blood cells, it means that any time that baby's blood gets into the mother's bloodstream, she's going to create the anti-rhesus antibodies. So how does the baby's blood get into the mother's bloodstream? This can happen at any what we call sensitizing events. So this could be a miscarriage after 12 weeks, abdominal trauma where there's been some bleeding inside the placenta and some blood cells have got across, or it could be at birth when there's obviously lots of bleeding and lots of mixing of mum and baby's blood. Usually this doesn't have much of an impact at the time because the mum will just destroy the blood cells that have got into her system. But in future pregnancies, what happens is those antibodies that the mum has developed will be able to cross the placental barrier because they're only very small proteins, and they'll get into the bloodstream of the baby and start attacking the baby's blood cells. As the baby's blood cells are hemolyzed or destroyed, that releases chemicals into the baby's body, particularly something called bilirubin. And bilirubin is responsible for creating jaundice. A slight jaundice in babies is normal, that's called a physiological jaundice. When the bilirubin level gets very high, it can cause significant brain damage and actually long-term learning difficulties and disabilities. This process of antibodies crossing across the placenta into the baby's bloodstream and causing a hemolytic anemia and a severe jaundice is called hemolytic disease of the newborn, or HDN. So the question is, how do we prevent this situation of the mum becoming sensitized? Well, we use something called anti-D immunoglobulins. And what these are is basically the anti-D antibodies, and we give them by an intramuscular injection at any event where the mum might become sensitized. So any time the baby's blood might have got into the mum's bloodstream. And what this injection does is it circulates around the blood and destroys any of the baby's blood or any of the blood cells in the mum that contain this rhesus antigen. And by destroying all of the baby's blood cells before the mum has an opportunity to launch an immune response, you prevent the mum becoming sensitized and developing her own antibodies against the rhesus antigen. So what we do is, in every new mum, every pregnant lady, we check their rhesus status. And if they're rhesus positive, we don't have to worry about rhesus incompatibility at all. She won't have any problems related to her rhesus group. But if the mum is rhesus negative, we have to assume that the baby is rhesus positive. And so what we do is we give her an anti-D immunoglobulin intramuscular injection anytime she might be sensitized to the baby's blood. So this would be things like late miscarriages after 12 weeks, abdominal trauma, or any bleeding during the pregnancy. We also give anti-D injections to mums at 28 weeks of gestation, and then we check at birth the baby's blood group by taking a sample of the baby's blood from its umbilical cord, and we give the mums an anti-D injection if it turns out the babies are rhesus positive. If the babies at birth are rhesus negative, mums don't need an injection.
Rhesus disease can largely be prevented by administration of anti-D immunoglobulin. This prevents sensitization when the rhesus-negative mother is exposed to her rhesus-positive baby. The anti-D immunoglobulin neutralizes any Rhd-positive antigens that may have entered the mother's blood during pregnancy. If the antigens have been neutralized, the mother's blood won't produce antibodies. This routine administration of anti-D immunoglobulin is called routine antenatal anti-D prophylaxis. Isoimmunization, such as rhesus isoimmunization and ABO incompatibility, anti-C, Tuffy antibodies, and KEL alloimmunization, are the causes of immune hydrops fetalis. Hydrops fetalis is a life-threatening condition that presents with an abnormal fluid collection in two or more cavities, compartments, mainly pleural effusion, ascites, pericardial effusion, and skin edema. There is also anemia and hepatosplenomegaly. Exchange transfusion is required in infants with severe hemolytic disease due to blood group incompatibilities or G6PD deficiency. It is used to manage severe anemia at birth or to treat severe hyperbilirubinemia which is not controlled by phototherapy and, where appropriate, intravenous immunoglobulin therapy. Now, please watch the following short video.
Hello, today's NICU Nugget is on exchange transfusions. Exchange transfusions are used less and less in the neonatal world just because of the advancement of other medications and techniques. However, sometimes it really is exactly what the baby needs, so it's still important that you understand it, and it also helps just a general understanding of the pathophysiology behind it. Most of the time, we do exchange transfusions for jaundice, or specifically for unconjugated hyperbilirubinemia. Most of the time, it's an immune-mediated hyperbilirubinemia. And so what we're hoping to do is get all that free, unconjugated or indirect bilirubin that's floating around the blood and get it out of the body. If that indirect bilirubin builds up, then it could cross into the blood-brain barrier and cause kernicterus. So what we're trying to do is make sure that that bilirubin level in the blood stays low enough that it doesn't cross into the blood-brain barrier. In immune hyperbilirubinemia, what we're also doing is removing some of those antibodies that are responsible for breaking down the red blood cells. And so getting rid of those antibodies will also stop the whole process of releasing more bilirubin. In neonatal hemochromatosis, which is thought to be also an antibody-mediated disease, more recently, double volume exchange transfusions are being used to try to get rid of those excess antibodies. So an exchange transfusion will get rid of the pigment that you're trying to get rid of, but could also get rid of antibodies or anything else that's bad that's floating around the body that you want to get out. So why is it called an exchange transfusion? What we're doing is basically exchanging the baby's blood. So we're taking out the baby's blood volume and replacing it with effectively donor blood. We call it a double volume exchange because what we're normally doing is replacing 2 volumes of the baby's blood. So a baby normally has somewhere between 80 to 85 mLs per kilo. So altogether we'd be removing 160 to 170 mLs per kilo because it's double volume, 2 times 80 or 2 times 85. Obviously, we're not doing this in one go. We're taking out a bit, then putting in a bit, then taking out a bit, then putting in a bit. And the amount that we take out altogether will reach about 160 to 165 cc's per kilo. So why do we do a double volume exchange transfusion? This is why. Obviously, you can't take out all the baby's blood and then just put in new blood. So we have to take it out in small aliquots at a time, anywhere between 5 and 15 mLs basically. So if you take out, for example, 10 mLs, and then you replace that with 10 mLs of the donor blood, and then you take out another 10 mLs, that second 10 mLs is not going to be pure baby's blood. Some of it is going to be some of the donor blood that you just gave. Mathematically, the washout of the infant's blood is basically a simple exponential function. So if you do a single volume exchange, so for 80 cc's per kilo, you take out 10, put in 10, take out 10, put in 10, until you get to 80 cc's per kilo, then you will end up washing out or removing about 63% of the baby's blood. If you do a double volume exchange, so you do it 10, 10, 10, 10, so it gets to 160 cc's per kilo, then you'll end up washing out about 85 to 86% of the baby's blood. If you do a quadruple volume exchange, then you'll end up washing out about 98% of the baby's blood. Obviously, that would be very time consuming and is associated with other risks. So basically, you're pretty much getting your most bang for your buck at double volume exchanges because you're getting 85 to 86% washout. So what blood do we use for the procedure? Obviously, we're taking out the whole blood, but what should we replace that blood with? If you remember or go back and look at the CBC lectures, blood is basically made up of 4 components: red blood cells, white blood cells, platelets, and then the plasma. So obviously, we need to be replacing red blood cells, and the basis for the donor blood is going to be red blood cells. If we're taking out 86% of the baby's blood and not giving any red blood cells back, then the baby would be extremely anemic and probably die. So definitely red blood cells. What about white blood cells? We generally do not want to transfuse white blood cells because those white blood cells will go inside the new body and attack that body. So that would be graft versus host disease from the donor white blood cells. What about platelets? If you remember, what we said about platelets is that, one, they are very redundant in that we have a lot of them, 250 to 300,000 of them, but really you're not going to have any bleeding issues unless that number falls below about 20,000. The second thing about platelets is that they're made very, very quickly. So the baby can continue to make platelets very quickly. So generally, we don't add platelets to the donor blood that we're giving, or we don't add WBCs either. So what about plasma? The plasma contains a lot of clotting factors. And remember that if you're missing even half your clotting factors, you can end up with severe bleeding issues. So we definitely want to replace that plasma to some extent. In fact, the blood that we end up giving is generally red blood cells reconstituted with plasma, or red blood cells reconstituted with FFP. So how is the procedure done? So like we said, you're pulling blood out and then returning blood. It's much easier if it's done with 2 operators, somebody's pulling and somebody's pushing, as well as if you do have both arterial as well as venous access. So it's great if you have an umbilical arterial line as well as an umbilical venous catheter, but you can also use a PAL, a peripheral arterial line, to pull the blood out, and you can use a peripheral IV to push the blood back in. You can also both pull and push from a double lumen UVC. So generally the aliquots that you use are about 5 mLs per kilo. So if you have a 3 kilo baby, then you can use aliquots up to about 15 mLs. And that's normally kind of the range that we use, somewhere between 10 to 15 mLs. It's very important that when you're working with someone, you're constantly communicating with them. It's very easy as you're doing this procedure to kind of just lose track of how much you've taken out and how much that person has put in. And the whole procedure should take between 1 to 2 hours if you're doing a double volume exchange transfusion. You don't want to go too fast and risk making mistakes, and you don't want to go too slowly either. So what risks can occur? Probably the most obvious one is that you're giving a huge amount of donor blood to this baby. So you have to be very, very careful that the blood is warmed exactly to the right temperature. If it's too cold, then it would go inside the baby and cause hypothermia. If the blood is heated to too high a level, then it can also cause hemolysis. So ideally, the blood should be warmed to about 34 or 35 degrees. So what risk factors are you worried about? Obviously, the biggest one is that you're worried about huge shifts in blood pressure or fluid volume causing hypo or hypertension. And then a lot of the other risk factors are related to the fact that you're giving donor blood. So donor blood has a lower pH. You're worried about acidosis developing in the baby. You're also worried about the chelating factors in the blood causing hypocalcemia. You're worried about the red blood cells hemolyzing, and red blood cells, or all cells, have potassium within them. So if there's a lot of hemolysis, then the potassium can be released and cause hyperkalemia, which obviously can be very dangerous. If there is bleeding, then logically you should be worried about not just the clotting factors that you're giving, but also platelets, and you should probably just think about immediately giving a platelet transfusion. Because of all these electrolyte abnormalities, when you're doing the double volume exchange transfusion, you should probably be getting chemistries and gases about every half an hour, just to make sure that the calcium and the potassium and the acidity aren't completely out of whack. There is also an increased risk of NEC with double volume exchange transfusions. Obviously, this is a much higher risk if the baby is preemie. Even so, even in full-term babies, we generally make these babies NPO and rest their gut, just to hopefully lower the risk of them developing NEC. One last thing to remember is that you have to get consent for the blood as well as consent for the procedure itself. Obviously, it has some severe risk factors, but like everything in medicine, it's all a balance between benefit and risk. So you really only want to do this procedure if it's really going to help survival or really help developmental outcomes. I hope you learned something today. Please remember to like and subscribe and let us know what else you'd like to hear about.
Hemolytic disease of the newborn can also be caused by an incompatibility of the ABO blood group. It arises when a mother with blood type O becomes pregnant with a baby with a different blood type. The mother's serum contains naturally occurring anti-A and anti-B, and can therefore cross the placenta and hemolyze fetal RBCs. HDN due to ABO incompatibility is usually less severe than rhesus incompatibility. In contrast to rhesus disease, about half of the cases of ABO-HDN occur in a firstborn baby, and does not become more severe in future pregnancies. Now, please watch the following short video.
Even though the mother has anti-B antibodies from the bacteria in the gut, those antibodies are... Welcome to Tala Talks NICU. Today we are going over part 3 in our series of jaundice. So go back and watch video 1 and video 2. And in the meantime, remember to like and subscribe and answer multiple choice questions. Today's video is on immune hemolysis and how that causes hyperbilirubinemia. I think a lot of people have issues with kind of understanding this and understanding why we care so much about certain of mummy's blood types. So after this video, you're going to get it. You're going to realize why some of mummy's blood types are more concerning than others. So today, let's start by talking about Rh disease or rhesus disease, which, as you all know, can be very concerning for the baby to end up with anemia as well as hyperbilirubinemia. So Rh disease happens when the mummy, so this is the mother, and this is the placenta here that I'm drawing. When the mother's red blood cells don't have the D antigen, and the antigen is just kind of any protein that's sticking on a red blood cell. We all have completely different antigens on different cells of our bodies. A lot of them are inherited. So the D antigen is one of the many antigens that decides whether somebody is Rh negative or Rh positive. So for the time being, let's just assume that this mummy is Rh negative, is D negative. So here we have an Rh negative mummy. So say we have a baby that for whatever reason was Rh positive. And we know that we're Rh positive because we have D antigen, that's a D by the way, sitting on the red blood cell. So in this case, this baby probably inherited the D antigen from daddy. So in this case, daddy is probably D positive, and so the babies ended up being D positive too. So there's a tear, and some of the baby's red blood cells end up in the mother's circulation. So now the mother is exposed to a foreign antigen in its blood supply. So what is the mother going to do? As soon as these red blood cells come into the mother's circulation, then the mother's immune system is going to make antibodies against those red blood cells. So if the mother makes enough of those antibodies, so we have a whole bunch of these antibodies against the D antigen, then those antibodies cross over into the placenta and then go to the baby's blood, and what are they going to do? they will set up a whole cascade to break down those red blood cells. So you end up with an immune, because it's an antibody-mediated hemolysis of those red blood cells. So Rh disease happens in mothers that are negative. So you could be O negative, B negative, AB negative, A negative. If you are negative, then the mother is at increased risk of making antibodies against her baby's red blood cells. Also, in Rh disease, it generally does not happen in the first pregnancy because the mother has to have had exposure to the red blood cells and enough time to make those antibodies that can then go back to the baby. So generally, unless something very severe has happened during that pregnancy, generally Rh disease will happen in the second, third, and pregnancies onwards. Just because most of the mixing between fetal and maternal blood generally happens at the time of delivery. Remember though, there are caveats to this. There are sometimes that mummies are pregnant without even knowing about it. And there's also the possibility that you do have some sort of severe mixing early on in one of the pregnancies. But essentially, Rh disease is when the mummy is negative and the baby is positive because the baby inherited it from daddy, and the mother has made antibodies that have then crossed the placenta and are destroying the red blood cells. Now let's talk about ABO incompatibility and how that causes immune hemolysis. There's something slightly different about the ABO incompatibility as opposed to the Rh disease. Remember, mummy will only have made anti-D or the antibodies to a baby with a negative rhesus factor if the mother was exposed to the fetal blood, whether it was a previous pregnancy or a really bad issue during that pregnancy. ABO is different from that, and the reason why is that we all have bacteria in our gut that have very similar antigens to the antigens that are displayed on red blood cells. So the bacteria in our gut have little antigens on them that look just like the B antigen of B-type blood cells. They have antigens just like the A antigens on the A-type blood cells. So what that means is, even if you've never had a baby, even if you've never had a blood transfusion, if you are a certain blood type, innately you will have the antibodies to the other blood types that you don't have. So for example, if you're O, and I am O, if I'm O, then because of the bacteria in my gut, naturally in my body I have anti-B and anti-A antibodies at all times. So logically, if you are an O mother, then you don't need a previous pregnancy or some sort of tragic thing to happen with mixing of fetal and maternal blood to be exposed to those antigens. As an O mommy, I already have the anti-A and the anti-B. So, as an O mommy, so you can see my red blood cells here, there isn't a single antigen on it, right? They don't have an A or a B antigen, or an AB, which is what the blood type AB would be. But I do have anti-A, and I always draw it like this, even though obviously they don't look like that. I have anti-A and I have anti-B antibodies. Now, the other very interesting fact about the ABO incompatibility is that O mummies naturally produce antibodies of the IgG type. So the antibodies that O mothers produce, the anti-A and the anti-B antibodies, are of the IgG type. IgG antibodies are capable of crossing the placenta. What's interesting is if you are an A mummy, so say you've got a little A on your antigens, so what type of antibodies would you produce if you're an A mummy? You would produce the anti-B antibodies. Those antibodies that A mummies produce are IgM antibodies. So IgM antibodies do not cross the placenta. So why do we care about this? We care about it because if you have an A mummy and a B baby, so say baby inherited the B type antigen from daddy, even though the mother has anti-B antibodies from the bacteria in the gut, those antibodies are not going to cross the placenta and cause hemolysis. They're stuck on the same side of the mummy. Same thing if the mummy was B and it was A. The only time we care about it is when the mummy is O. So when the mummy is O and doesn't have any antigens, then she has formed antibodies of A and B that can cross the placenta. So in an O mummy, say the baby ends up being B, those B antibodies can cross the placenta, go into the fetus's bloodstream, attach to the antigen on the red blood cell in the baby, and then set off a chain reaction that causes it to hemolyze, so causes that red blood cell to break down. So we worry about ABO incompatibility when the mummy is O. Remember that. When the mummy is O, we worry about ABO incompatibility. When the mummy is B or A or AB, then the antibodies that she has made, if she's made any, do not cross the placenta. So we do not have to worry about hemolysis. So the blood types that we would worry about most that the mother had would be the O blood type as well as any negative blood type. So whether that's A, AB, B, O. Those are the ones that if you see that in the mother and you see a high bilirubin level, you start thinking, am I missing a hemolytic process going on here, an immune hemolysis? So the other thing that you should also know is that this can actually start during pregnancy with the antibodies going over into the fetus bloodstream. But those antibodies, even after the baby is born, can stick around for weeks. In fact, antibodies from mommy can stay around for till about 6 months of age. The peak issue with the high antibodies still breaking down the red blood cells is kind of within the first week or so of life. After that, even if there is continued hemolysis, it occurs at a much lower rate. But it's that first week of life, if there are a lot of maternal antibodies that are causing hemolysis, that you really have to be worried about the bilirubin. So I hope that you kind of understood that process. Again, remember, you worry about mummies when they're O or they're negative. So thank you for watching. Remember to like and subscribe, go answer the multiple choice questions, and we just want to thank you for being here. Thank you.
G6PD is an inborn error of metabolism. An enzyme and deficiency leads to free radical-mediated oxidative damage to red blood cells, which in turn causes hemolysis. It is an X-linked recessive disorder, and thus more often affects males. G6PD deficiency has a high prevalence in people of African, Asian, and Mediterranean descent. The deficiency of G6PD will induce an accelerated rate of hemolysis that causes rapid rise in SBR, generated faster than it can be conjugated. There is also a risk of bilirubin-induced neurologic dysfunction and kernicterus. When investigating symptoms, history taking is essential, followed by clinical examination. Check serum bilirubin levels, and perform a group and direct antiglobulin test. The DAT, or Coombs test, is the test that is done on the newborn's blood sample. The test is looking for foreign antibodies that are already adhered to the infant's red blood cells, and can cause hemolysis. The test, historically called the Coombs test, was first described in 1945 by Cambridge immunologist Robin Coombs. Suspected hemolytic disease of the newborn, due to either rhesus disease or ABO incompatibility, is one of the most common reasons for requesting a DAT in newborns. Investigations should include blood film, bilirubin level, CRP, blood cultures, urine for C and S, urine and bloods for metabolic screening, G6PD, torch screen. So why these specific tests? The cornerstone of care is close monitoring, investigations, and anticipatory management. This should include blood film for HB, anemia, hemolysis, and blood cell disorders, bilirubin level for split bilirubin, CRP, an inflammatory marker for infection, blood cultures for infection, urine for C and S for infection, urine and bloods for metabolic screening for G6PD, torch screen for viral infection, and thyroid function tests. Consider how you would explain pathological jaundice to anxious parents, and why you are carrying out specific tests on their baby. The following conditions can also cause neonatal jaundice, often due to liver enzyme problems, but they are rarer. These include Gilbert syndrome and Crigler-Najjar syndrome. For more information on these conditions, please use the links on screen. In prolonged jaundice, the same investigations as before should be carried out, but should also include liver function and thyroid function tests. The concern in prolonged jaundice is the existence of biliary atresia, which requires urgent treatment for positive outcomes. As in all cases, the cornerstone of care is close monitoring, investigations, and anticipatory management. In summary, neonatal jaundice can generally be divided into two types: physiological and pathological. Physiological jaundice is caused by an increase in RBC with a shorter lifespan and abnormal metabolism of bilirubin. It appears after 2 to 3 days of birth, and it can disappear by itself in about 1 to 2 weeks after birth. Pathological jaundice appears within 24 hours of birth, and the baby's serum level of bilirubin continues to rise over time. The jaundice can last more than 2 weeks for full-term babies, and last more than 4 weeks for premature babies, during which time the jaundice may be recurring or worsening. Causes of pathological jaundice include infections, congenital biliary malformations, and neonatal hemolysis. If not diagnosed and treated, it can lead to irreversible and life-threatening bilirubin encephalopathy, with varying degrees of neurological sequelae associated with the neurotoxicity of high-level bilirubin. When treating babies with jaundice, be vigilant. Monitor and plot SBR levels. Use phototherapy. Provide feeding assistance and support. Consider supplemental feeding or IV fluids. Intravenous immunoglobulin can be used along with phototherapy in cases of rhesus or ABO, hemolytic disease. Please note that intravenous immunoglobulin treatment can be controversial, so please check your clinical guidelines. For more information, please use the link below. Thanks for watching.